Welcome to Pediatric Case Review. In today's lecture, we'll discuss meningococcemia in pediatric patients, a potentially devastating infection that requires rapid recognition and management. This presentation aims to provide practicing pediatricians with an introductory overview of the epidemiology, clinical presentation, diagnosis, and management of this serious condition. Let's begin with understanding who is most at risk for meningococcal disease. A pediatric hospital in your region notes an increase in meningococcal cases over the past month. Which age group is most frequently affected by meningococcemia? Is it A, neonates from 0 to 28 days? B, infants and children under 5 years? C, school-age children from 5 to 12 years? Or D, adolescents from 13 to 18 years? The correct answer is B. Infants and children under 5 years are most frequently affected by meningococcemia, with the highest incidence occurring in those under 2 years of age. A second, smaller peak occurs during adolescence. This age distribution relates to immunological factors, particularly the waning of maternal antibodies and the immaturity of the immune system. Meningococcal disease shows seasonal variation with peaks during winter and early spring months. Different serotypes predominate in different regions, with groups A, B, C, W, and Y being most common globally. Let's explore the underlying pathophysiology of meningococcemia. A 3-year-old presents with rapidly progressive purpuric rash and fever. What is the primary mechanism causing the skin manifestations in meningococcemia? Is it A, direct bacterial invasion of the skin? B, allergic reaction to bacterial components? C, endothelial damage and microvascular thrombosis? Or D, toxin-mediated epidermal necrosis? The correct answer is C. The characteristic rash in meningococcemia results from endothelial damage and microvascular thrombosis. Neisseria meningitidis releases endotoxin that triggers an inflammatory cascade, leading to endothelial cell injury and activation of the coagulation system. This process can progress to disseminated intravascular coagulation, or DEC. The resulting microvascular thrombosis and hemorrhage produce the classic purpuric and petechial skin lesions. This vasculopathy can affect multiple organ systems, explaining the multi-system failure seen in severe cases. Now let's discuss the clinical presentation. A 4-year-old is brought to the emergency department with 12-hour history of fever, irritability, and a new rash. Which clinical feature is most specific for meningococcemia? Is it A, high fever and headache? B, non-blanching purpuric rash? C, photophobia and neck stiffness? Or D, vomiting and poor feeding? The correct answer is B. A non-blanching purpuric rash is the most specific clinical feature of meningococcemia. This characteristic rash typically begins as small pink macules that rapidly evolve into petechiae and purpura. The rash can appear anywhere, but often affects the trunk and lower extremities. Importantly, the rash may be absent in early disease in 10 to 20% of cases. While the other symptoms listed are common in meningococcal disease, they are less specific and occur in many other infectious conditions. Let's continue with clinical presentation. A 2-year-old presents with fever, lethargy, and a few scattered petechiae. Which early clinical sign may indicate impending shock in meningococcemia? Is it A, cool extremities with prolonged capillary refill? B, severe headache? C, photophobia? Or D, nuchal rigidity? The correct answer is A, cool extremities with prolonged capillary refill is an early sign of impending shock in meningococcemia. This reflects peripheral vasoconstriction as the body attempts to maintain central circulation. While the blood pressure may initially remain normal or even elevated, tachycardia is usually present. Other early signs of shock include tachypnea, altered mental status, and decreased urine output. The progression from these early signs to fulminant shock can occur rapidly, sometimes within hours, highlighting the importance of recognizing these subtle clinical findings. Moving to examination findings. A 5-year-old with suspected meningococcemia has normal vital signs except for tachycardia. Which physical examination finding requires immediate intervention? Is it A, scattered petechiae confined to the trunk? B, rapidly expanding purpuric lesions with spreading edge? C, mild neck stiffness without other meningeal signs? Or D, mild pharyngeal erythema? The correct answer is B. Rapidly expanding purpuric lesions with a spreading edge indicate aggressive disease progression and extensive endothelial damage. This finding correlates with severe disease, high bacteremia, and increased risk of shock and disseminated intravascular coagulation. When observed, these lesions warrant immediate antimicrobial therapy, even before diagnostic tests are completed, along with aggressive supportive care. While scattered petechiae and mild neck stiffness may be present in meningococcemia, they don't necessarily indicate the same urgency as rapidly spreading purpuric lesions. Let's discuss examination findings that indicate disease severity. A 3-year-old with fever and rash is being evaluated for meningococcemia. Which combination of findings suggests the most severe disease? Is it A, fever, irritability, and maculopapular rash? B, hypotension, tachycardia, and decreased level of consciousness? C, vomiting, headache, and photophobia? Or D, rhinorrhea, cough, and ear pain? The correct answer is B, hypotension, tachycardia, and decreased level of consciousness represent the classic triad of meningococcal septic shock. These findings indicate systemic inflammatory response syndrome with significant hemodynamic compromise and end-organ hypoperfusion. Patients with this combination have significantly higher mortality rates and require immediate resuscitation, antibiotic therapy, and often intensive care management. The other combinations may represent early disease or alternative diagnoses, but don't suggest the same degree of physiologic compromise. Now, let's explore the diagnostic approach to meningococcemia. A 4-year-old presents with fever, petechial rash, and lethargy. What is the most important initial diagnostic test for suspected meningococcemia? Is it A, lumbar puncture, B, blood culture, C, complete blood count, or D, skin biopsy of rash? The correct answer is B. Blood cultures are the most important initial diagnostic test for suspected meningococcemia. They provide definitive diagnosis by isolating Neisseria meningitidis from the bloodstream. Ideally, blood cultures should be obtained before antibiotic administration, though treatment should never be delayed to obtain cultures in critically ill patients. Multiple blood culture sets increase diagnostic yield. While complete blood count and inflammatory markers help assess disease severity, and lumbar puncture is important if meningitis is suspected, blood cultures remain the gold standard for diagnosis. Continuing with diagnostics, a 7-year-old with suspected meningococcemia has already received antibiotics at a referring hospital. Which test is most likely to confirm the diagnosis now? Is it A, repeat blood culture, B, PCR of blood or cerebrospinal fluid, C, urinalysis, or D, plain chest radiograph? The correct answer is B. Polymerase chain reaction testing of blood or cerebrospinal fluid is most likely to confirm meningococcal disease after antibiotic administration. PCR detects bacterial DNA rather than viable organisms, so it remains sensitive even after antibiotics have been given. This molecular method offers higher sensitivity than cultures in patients who have received prior antimicrobial therapy. Additionally, PCR provides rapid results, often within hours, compared to the days required for culture. This can be critical for confirming the diagnosis, guiding ongoing management, and initiating public health measures. Moving to treatment considerations. A 6-year-old presents to the emergency department with fever, petechial rash, and hypotension. What is the first priority in management? Is it A, obtain blood cultures, B, administer intravenous antibiotics, C, perform lumbar puncture, or D, transfer to tertiary care center? The correct answer is B. Administering intravenous antibiotics is the first priority in managing suspected meningococcemia. Studies have shown that each hour of delay in antibiotic administration increases mortality. While obtaining blood cultures is important for diagnosis, it should never delay antibiotic therapy in a critically ill patient. The empiric antibiotic of choice is typically a third-generation cephalosporin such as ceftriaxone or cefotaxime. Lumbar puncture may be contraindicated in an unstable patient, and transfer arrangements, while potentially necessary, should occur after stabilization and initiating antibiotics. Continuing with management approaches. A 5-year-old with confirmed meningococcemia is in the ICU with shock requiring vasopressors. Which adjunctive therapy should be considered? Is it A, corticosteroids, B, fresh frozen plasma, C, exchange transfusion, or D, plasmapheresis? The correct answer is A. Corticosteroids should be considered as adjunctive therapy in meningococcal septic shock. Patients with severe meningococcemia may develop relative adrenal insufficiency due to the stress response and direct effects of endotoxin. Low-dose hydrocortisone may improve hemodynamic stability in patients with catecholamine-resistant shock. The other options have limited evidence supporting their routine use. Fresh frozen plasma may be indicated for coagulopathy, but not as a primary therapy. Exchange transfusion and plasmapheresis remain experimental approaches without strong evidence for routine use in pediatric meningococcemia. Let's discuss complications of meningococcemia. A 4-year-old survivor of severe meningococcemia has developed skin necrosis of the digits. Which pathophysiologic process is most responsible? Is it A, direct bacterial invasion, B, disseminated intravascular coagulation with microvascular thrombosis? C. Immune complex deposition? Or D. Secondary bacterial infection? The correct answer is B. Disseminated intravascular coagulation with microvascular thrombosis is the primary process responsible for tissue necrosis in meningococcemia. The endotoxin release triggers an overwhelming inflammatory response and coagulation cascade activation, resulting in widespread microvascular thrombosis. This process causes tissue ischemia and necrosis, particularly in peripheral tissues such as digits, where perfusion is already limited. Severe cases may require surgical debridement or amputation. Other complications of meningococcemia include adrenal hemorrhage, myocarditis, arthritis, and neurological sequelae if meningitis is present. Let's explore risk factors for meningococcal disease. Which patient has the highest risk for developing invasive meningococcal disease? Is it A. 6-year-old with sickle cell disease? B. 10-year-old with asthma? C. 14-year-old with complement deficiency? Or D. 2-year-old with history of prematurity? The correct answer is C. A 14-year-old with complement deficiency has the highest risk for developing invasive meningococcal disease. Deficiencies in the terminal complement pathway, especially components C5 through C9, increase the risk by 1,000 to 10,000-fold compared to the general population. These patients often experience recurrent meningococcal infections with unusual serogroups. Other significant risk factors include functional or anatomic asplenia, HIV infection, and living in crowded conditions like college dormitories or military barracks. Sickle cell disease primarily increases susceptibility to encapsulated organisms like Streptococcus pneumoniae rather than Neisseria meningitidis. Now let's discuss prevention strategies. A 2-year-old was treated for meningococcemia. Which of the following contacts requires chemoprophylaxis? Is it A. a classmate at daycare who sits at the same table? B. the emergency department triage nurse? C. a household family member? Or D. a patient who was in the adjacent hospital bed? The correct answer is C. A household family member requires chemoprophylaxis. Household contacts of patients with meningococcal disease have a 500 to 800 times increased risk of developing the disease compared to the general population. Prophylaxis should be provided to all household members, regardless of age, as well as to intimate contacts and daycare contacts with direct exposure to the patient's oral secretions. Healthcare workers generally don't require prophylaxis unless they had direct exposure to respiratory secretions, such as during intubation without proper protection. Recommended prophylaxis regimens include rifampin, ciprofloxacin, or ceftriaxone, depending on age and contraindications. Let's discuss vaccination strategies. Which meningococcal vaccine should be administered to a 12-month-old with complement deficiency? Is it A. MenACWY conjugate vaccine only? B. MenB vaccine only? C. both MenACWY and MenB vaccines? Or D. no vaccines until age 11? The correct answer is C. Both MenACWY and MenB vaccines should be administered to a 12-month-old with complement deficiency. Children with complement deficiencies are at extremely high risk for invasive meningococcal disease and should receive comprehensive protection. The MenACWY conjugate vaccine can be administered to high-risk infants starting at 2 months of age, with specific dosing schedules based on the product used. While MenB vaccines are FDA approved for individuals 10 years and older, they can be considered for younger children with high-risk conditions. Both vaccines are needed because they protect against different serogroups, and neither provides complete coverage alone. Let's apply our knowledge with a case study. A 6-year-old presents with 12-hour history of fever, lethargy, and rapidly progressing purpuric rash. Labs show leukopenia, thrombocytopenia, and elevated C-reactive protein. What is the single most important next step? Is it A. CT head before lumbar puncture? B. immediate intravenous ceftriaxone? C. fluid bolus and vasopressors? Or D. transfer to nearest tertiary center? The correct answer is B. Immediate intravenous ceftriaxone administration is the single most important next step. This clinical picture strongly suggests meningococcemia with impending septic shock. Early antibiotic therapy is the most critical intervention affecting mortality. While fluid resuscitation and vasopressors may be needed, antibiotics should be the first intervention. Diagnostic studies should not delay antibiotics, and transfer arrangements should be made after initiating treatment. The combination of fever, lethargy, rapidly progressing purpuric rash, and laboratory abnormalities constitutes a medical emergency requiring immediate antimicrobial therapy. To conclude our discussion on meningococcemia in pediatrics, remember that early recognition and intervention are crucial to survival. The characteristic purpuric rash, along with fever and altered mental status, should trigger immediate antibiotic administration. Risk factors include young age, complement deficiencies, and close contact with infected individuals. Prevention through appropriate vaccination and chemoprophylaxis for close contacts remains essential. Thank you for watching Pediatric Case Review. If you found this presentation informative, please subscribe to our channel for more educational content on pediatric conditions. If you have any questions, please leave them in the comment section below.